welcome back to the second session of this video series on cardiac surgical arrest. I'm joined once again by Tara Bartley from SCTS, Christina Ruiz-Sagria from EACS, and John Whitlock from the STS. At the conclusion of our last session, you all stated that you thought your most challenging rhythms were bradyarrhythmias, so that's what we'll be talking about today. The arrest algorithm approved by all of our societies indicates the pathway for bradyarrhythmias and asystole, as you see here. We should first attempt epicardial pacing if wires are there. If unsuccessful, then begin CPR before initiating external pacing. And although it doesn't state anything about IV meds, many suggest IV chronotropes like a small dose of epinephrine could be initiated at this point. So I'd like to begin with Tara. How do you implement the bradyarrhythmia protocol? Do you see it as is shown here? Do you see any value in using a chronotrope like epinephrine in this algorithm?
Thanks, Jill, and good evening, everybody. So I think we'll come on to sort of the bradyarrhythmias in more detail in a bit, but I think within the arrest situation, if we have no cardiac output, we need to just have a look to see whether we are in asystole or whether we are in a PEA. So while we're in a shockable or a non-shockable rhythm in terms of these two non-shockable rhythms. In terms of giving electricity or pharmacology, then what we need to do is ensure that we ultimately get in the chest in under 5 minutes, and we prioritize that. I think in terms of any delay, what we say is that don't do anything other than get into the chest unless there is a delay. In terms of pharmacology, our cohort of patients is very different from the routine cardiac arrest patient in an out-of-hospital arrest situation, or even in an arrest situation in hospital for something that isn't sort of based around cardiac surgery. We've been in for cardiac surgery, we've got suturing, we've got delicate tissue, we've got post-operative, damage. And if we start to give something like adrenaline and it's not monitored very carefully, then we are testing all those suture lines. And what we don't want to do is turn an arrest that wasn't sort of primarily something that we'd caused into something that is the person by the bed responsibility. So in essence, the protocol doesn't give adrenaline. Now, there will be an exception further down the line, with a particular clinician, a senior input at tiny incremental doses, but we definitely don't advocate that at this stage.
Thank you. Christina, is that your practice as well?
Yeah, and I think CALS clearly came into because you wanted a protocol for people who is there during the arrest. So maybe it's not the most experienced people, but maybe it's mainly nurses or the junior doctors. So you don't want them. That's why I think epinephrine or any inotropes, you get them out of the equation because you want them to do something quick. You wanted to do something that is going to help the patient without harming. And as Tara said, probably the best idea is to start to do shocks if it's a shockable rhythm, or just compressions if it's a non-shockable rhythm. That will give you enough time for the experienced people to come in and then decide if they want to give inotropes and how to give them. Yeah, because again, you need to be very careful. As Tara said, there is delicate tissues, there is complex operations, there is aorta surgery that you don't want to give any doses that can bring your blood pressure and dissect the aorta or cause any damages. I think that's how good is CALS, in the sense that you want something quick, well done, and then that is going to give you or buy you enough time for bring the experienced people and then decide further with them.
Thank you. So I've heard from both of you that you're not advocating epinephrine. And again, it's not in the algorithm at all. But one thing's before I'll ask John, what about the sequencing? I know we bring our patients back from surgery with those external pads in place. So we would be able to deliver that external shock pretty quickly. So we might go ahead and deliver a shock before starting compressions. but wouldn't give epinephrine. John, what's your practice? Are you able to initiate external pacing rapidly, or how do you implement this algorithm?
Yeah, our practice is not to have pads on patients when they come out of the operating room. I would say that my biggest challenge with the bradycardia algorithm is the fact that there's many reasons that could cause the bradycardia. So if the cause is a sinus bradycardia, I, we would treat that a little differently than a complete heart block, right? So the use of a chronotrope kind of will be driven more by that, but we really emphasize the fact that we need to open the chest within 5 minutes. Something that I've started to emphasize in our practice is when the epicardial pacing wires are not working the way we want them to, is to take time to change the polarity
Mhm.
while we're doing compressions, because that might help.
So you bring up a really interesting point. Thank you, all of you. A lot of these rhythms, pacing is going to be our strategy, and that really requires some level of expertise among the providers. So, John, is that why you think this rhythm is such a challenge? Is because pacing is required and pacing is a complex skill?
We spent a lot of time training our nurses on epicardial wires, and they are testing the thresholds every shift. So they touch them every day. So we have a pretty high level of confidence working with wires. The challenge for me is that the other recommendations or pathways in the CALS protocols are pretty straightforward. So shockable rhythm. That's not much to talk about there. PEA is PEA. Bradycardia falls into a different category because there's different opinions about how we manage bradycardia, including pharmacology, if pacing is not working.
Mhm. Okay, yeah, so I get what you're saying. You get to
So,
that algorithm pretty quickly. You're
yeah.
opening.
For us, the pacing wires are pretty easy to manage.
Good. Tara, why do you think these rhythms are such a challenge?
Well, I would completely endorse everything that John just said. I mean, ultimately, the decision making is pharmacology or electricity. The thing that determines that is the stable or the unstable patient. So, in the stable patient that needs augmented with a cardiac rhythm, you could perhaps look at some pharmacology and take a more gentle approach. And that's by the sort of judged by the blood pressure and the hemodynamics of the patient. In the unstable patient, then you need to have some electricity and you need to manage the heart rhythm by increasing the heart rate. So in a sort of, a sustained way that gives you time to be able to look at the underlying rhythm. So we need to look at what is the sort of the pathology, as John says, of the rhythm itself. If it's slow, what sort of bradycardia have we got? And is it one that's deteriorating? Is the QRS narrow or wide? Is it regular or irregular? Is it something that is perhaps attributed to swelling and edema post-operatively, or the primary surgical event being a valve rather than a coronary artery bypass? And so all these things inform your immediate action, but also the things that you consider as to why, how you will progress with the clinical management plan. You need to review, the patient's medications from pharmacology. Is it something iatrogenic that we've done other than the surgery? Stop anything that you think could be causing it. And then it's that whole process around if somebody has a no underlying rhythm, or they have an underlying rhythm that's not compatible with a adequate cardiac output, the security about maintaining what environment is that person nursed in. in case those wires become detached? What's the skill level of the staff around there in case those wires become detached? You know, if you've got a rotational medics and they've never met pacing before, then you surely have got to have somebody who is around who knows what they're doing. You know, what's your equipment like? What's your backup if it does become detached? Have you got another box? Have you got an external system that can replace it? And in terms of future management, at what point are you looking at, you know, maximizing the electrolytes, maximizing time for the heart to recover, and what are the inflammatory markers doing? And if you're going to need a longer term device, such as a permanent pacemaker, what's the decision-making process on a daily basis that reviews when that's indicated, if at all?
And once you decide to put them in, you'll realize they're on anticoagulants.
That's why I said early review of medication.
Christina, why do you think this is a challenge? And I'm going to ask you to add one thing. Do your staff nurses check thresholds every day, or is that something your advanced providers do?
So I was going to say that I think the key on this is a good, healthy checkup every morning with your thresholds. I think it's really important to realize when the thresholds are going up, because our machines, they have limitations. I know that on the other side, the cardiologists, they tend to delay any referrals for bradyarrhythmias to them for consideration of pacemaker or for other things, because yes, I understand there is a process post-op that the tissues, they need to recover, and most of the time it's just they need a few days to recover. I think you need a good plan, and I think if you check in your thresholds every day and then you realize that this is increasing, is when you need to raise the concerns, is it? And when people need to be aware of those things. The problem is when people miss that. Yes. And I think that's why I think it's important. I think in our unit, we had nurses checking thresholds. It's a part of the competency pack in ITU. But I think that training, I had this conversation the other day with the nurses in ITU. I think for pacing, it's very difficult because you can go through any training that you want, but you really need to have the pacing box in your hands and have a play with the box and have an answer from the patient. And you only can do this on a patient, yeah? So training in a more calm, in a room or during calls, when you're doing calls, it's very difficult. I'm open to suggestions. I think there is a few places that they were developing a machine that you could just play with it and people could train. I'm guessing in the world of VR, augmented reality, that's probably something that we should invest. But I think the key in here is to do a good checkup every morning or even twice a day.
Thank you. I think you guys are absolutely right. And it used to be years ago that our staff nurses did this. And now, you know, it really is, since we've got advanced providers and they round every day, it's kind of fallen to them. So I'm not going to quibble over who's accountable for it, just that I think we're all agreeing this must happen once a day. There needs to be an assessment of both sensing and capture thresholds to hopefully not get caught off guard in the middle of the night. Christina, I'm going to hit you again. We advocate for the use of epicardial, but I'm seeing fewer wires. Some of our patients come out without wires these days. Are you seeing this in your practice? And if so, you know, how does that change your training?
No, we're still seeing lots of pacing wires in our setting. For valves, always. For cavity, kind of depends. I think the junior consultants or the junior surgeons, they tend to use pacing wires always until they feel more comfortable in their careers, and then they go a bit more wild without. But I think at least in UK, at most centers, they use wires. I'm not sure in Europe, but I think they use wires all the time. I don't see that. I don't see that in my practice.
John, do all your patients have pacing wires, A and V?
Yeah, the only change in practice I've noticed over the past year or two is that not all patients come out with both A and V wires. There's been a trend for some surgeons to just place V-wires in certain patients. I have to say that because the nurses in my unit, I think part of it is because they take such pride in their knowledge of wires, get very frustrated if they don't have both sets of wires. They like testing them and they feel a little caught off guard when they don't have them at their disposal. So that is that will become controversial if that's going to be a practice change for us to deal with.
Got it. And how about you, Tara? Your patients always have at least V-wires?
I think as both John and Christina said, things are evolving. Younger generations of surgeons are coming through. Ultimately, we need to look to the future in terms of what's the best way to manage patients, and we need to respect our colleagues in terms of their decision making and their surgical practice and what they do. I think Christina said quite rightly, most valve patients should be quite ambitious to come out without any wires. In my experience, a little bit of no wires, but the majority of patients are coming out. I think the key take-home message really is that whatever the patient's got, wires or no wires, we reported last week, didn't we, that it's best to have the CAL set up in place. Everybody practiced, beginning of a shift, identify key roles. That third role who's on defib, if they have a patient come out without wires, then they need to know how to have a cart ready near and how to put external pacing on quickly. And actually, it's no different from a cardiac arrest when you put external pads on to shock people. It shouldn't take an excessive amount of time, and you should be able to put the pads on and start externally pacing and gain enough cardiac output. So as respect for our professional colleagues who choose not to use them, perhaps we should be sort of looking a little bit more in terms of our risk management from that side of things. And then there is, of course, that other side of the CALS protocols in terms of the course itself that looks at the deteriorating patient. And so apart from the sudden loss of capture or the sudden loss of cardiac output, we should be alerted to the fact that our patients are deteriorating, and actually we do need to be looking at what's the underlying cause, and how can we reverse that and stabilize patients.
Absolutely. And I think that what I'm hearing, and I would absolutely support, is there may be patients that have A wires, V wires, none. And so it's just critical that when this patient arrives in our unit, we understand what they have and be prepared for responding to an emergency. And it was our practice really is that the patient comes out with a posterior pad in place. We, got different pads. They were using these in the OR anyway. And so then we just were able to get an accompanying anterior pad. So we leave the posterior pad in place, add a new anterior, and then we're ready to set up pacing if we need to. But again, as long as we're saying the same thing, as long as your staff know what to expect, I think we'll be in good shape. My next question, I just want to give you a little preamble here, if you bear with me. The CSR CALS protocol advocates that you start compressions, in the algorithm if you failed pacing efforts. And they suggest that compression should be started in standard fashion at a rate of 100 to 120 beats per minute. And yet there is some controversy about this. In the 2023 American Heart International ILCOR guidelines, the consensus is that hand position is graded as weak, very low certainty evidence. So even the American Heart Association and their international colleagues are saying there's really poor evidence that your hands should be placed in this manner. There's additional data. I thought this study was fabulous. It was from Huang, HWANG, in 2009. And they used echo during CPR, and they indicated that in their patient population, 100% of the patients had the LV outflow tract narrowed with standard CPR, and almost half had a greater than 50% reduction in LV outflow tract. So there's data that says that where we're putting our standard hand position is wrong. And further, I've never met a surgeon that wanted you to put your hands directly on their incision to compress. So my question is, and I'm going to start with Christina this time, what do you see practiced regarding hand position if CPR is necessary in these patients? And is that what you're teaching?
We don't specify where to do the CPR. I will say just do CPR wherever you need to do CPR. I wouldn't change protocols. I mean, I know there is an incision. I know it's been closed. Sometimes you can have a patient which is packed, but we never make a distinction on that. I mean, I wasn't aware of that data that you just explained to us, but I think in that situation, if you need to do compressions, I mean, the alternative, what it is, it's doing an abdominal, which we know that the results are not very good. So, and it doesn't matter, you still have your sternum in there, so you can do cardiac massage. I don't know what my other colleagues will say, but I'm a bit lost on that question. I don't
Wrong answers
I
here.
don't tend people to say not do it where the incision is. I think that's where you need to do it. Is where you always been taught to do CPR. So,
John, what about you?
This is something that I've struggled with for many years because I feel like the messaging around compressions is very confusing to newer staff, especially because we do discuss the potential complications of external compressions with a fresh sternotomy, so which gives them hesitation to perform that right from the get-go. I just recently started teaching, and I would highly recommend other centers adopt this concept of looking at the monitor while we're doing compressions, because we do have an arterial line, and that if we're getting an adequate pressure by watching the arterial line, then we're pushing just hard enough and we are perfusing the patient. Or if the compressions aren't working, we'll know right away. So that is something that has kind of developed over the most recent months in the way I approach compression teaching.
Good. And that absolutely is mentioned in the guideline itself. And, you know, that's one of the advantage I think that we have with this patient population is the vast majority have an art line. So you know if you're being successful with your compressions wherever they are. Tara, what about you?
So I think if we look at the ALS guidelines for the cohort of patients that are non-cardiac surgery, then, you know, that there is a suggestion that you should place your hands in the lower half of the sternum. I think with our cohort of patients, the two complications that we most fear are one in the immediate process, that the damage to the heart is done through a wire, or there's, you know, immediate damage done that will cause bleeding and further trauma. And I think in the longer term, what we worry about is that we cause potential osteomyelitis and damage to the wound and healing. So I completely understand why our surgical colleagues would not want us to do that unless it was necessary. And built into the CALS protocol is, you know, if it is a non-shockable rhythm, if it is a shockable rhythm, then you want to be have all your equipment nearby. And we've already talked about how to prep staff, teach staff, and have a process in place at the beginning of the shift to manage an emergency. And you do not do cardiac massage unless the shock is delayed beyond 1 minute. And then we teach, as John just said, the minimum amount of compression to get an adequate cardiac output, bearing in mind you've got to have circulating volume to get a cardiac output anyway. And then finally, the whole aspect about, you know, it's a reversible cause, probably, most likely iatrogenic from something we've done. Therefore, we want to get into the chest. So again, minimum cardiac massage and into the chest very quickly. Now, the CALS protocol suggests for the shockable rhythm that you should be gowned and gloved and ready to get into the chest, the two people that are going to do it, by the time the third shock is delivered. And a slick team who's used to doing it would have no trouble doing that, providing they have all the equipment and everybody is communicating effectively. For the patient who is in a non-shockable rhythm, you're actually looking then at the similar 45 seconds to deliver shock. So 45 seconds without compression and get straight into the chest. So I think what we're saying here is that you don't give massage unless there's a delay. even if it feels uncomfortable to stand there. The delay shouldn't be, should be under 1 minute in terms of what we want to do in terms of getting into the chest. And beyond 1 minute, if you are going to do massage, it's done at the lower half of the sternum rather than over the heart itself. And it is actually done to a minimum amount of pressure for adequate output.
This is fascinating. I've done some literature review on this, and because I have my program and I have to teach others around the country, and I have yet to hear a surgeon say, put your hand here. And so based on this evidence, what I've said in my training program to others is your surgeon needs to be involved with your course. We are going to teach standard CPR, even though it may not be great unless your surgeons come in and say, this is what I want to do. I will not stand in the way of a surgeon, as mine did, saying, I don't want the sternum here. So they have us actually either hand on either side of the sternum or flat hand on top of the sternum. But the bottom line is, looking at the art line, you know exactly whether or not you're being effective or not. And the goal is always to get the chest open as quickly as possible. CPR is a placeholder until you can do that. So if anybody out there is interested in fascinating research, I would love to see someone research hand position in the cardiac surgical arrest patient.
And I think, Jill, if I may, all of us as a consensus have said that the evidence supports that cardiac massage is not that effective.
Exactly.
And it is only as a holding measure, and it's not a solution in our patients and in general patients as well.
Exactly. And there have been case reports of wires, the sternum, shredding the right ventricle, causing bleeding. So it's not a benign situation, but I always instruct people, if you have to do compressions and it's time in the algorithm, then you do so. Watch your art line. Okay, so now here's our final question. This is a yes/no question. This is our teaser for next week, where we'll be discussing the tachyarrhythmias and the shockable rhythms. So starting with Christina, do you advocate any form of artificial external compression device be used for CPR in your cardiac surgical population? Yes or no?
For me, it will be a no, for sure.
Okay. All right. How about John? Do you advocate for the use of any external compression like a Lucas in your patient population?
No.
No. Tara?
Not in our cohort. Definitely no.
Not in our cohort. That we're going to make that a solid 4 no's, and we'll bring up that conversation next week. If you look at this, I challenge you to take a look at your hospital policies. As of this moment, there are no manufacturer contraindications. So we'll take this up next week. And with that, I thank Christina, John, and Tara for your participation today. Just like last session, this was absolutely fun and fascinating, and I really appreciate picking your brains on this subject matter. I thank the audience for tuning in, and we'll appreciate connecting with you next time. Thank you and goodbye.
Thank you. Good night.
Thank you.